Thank you for taking time from your busy day to watch this special presentation from the El Paso County Medical Society. I'm Dr. Joel Hendricks, President of the El Paso County Medical Society, and it is my hope that you will find our program of great interest, educational, and informative about the medical care provided by some of our best physicians in our country, right here in the borderland. From all of us at the El Paso County Medical Society, please enjoy tonight's program.
There are many different types of neurosurgical conditions. We're going to talk about diagnosis and treatment of issues affecting the nervous system, including the brain, the spine, peripheral nerves, and especially craniofacial surgery this evening. If you have any questions regarding this show or any other show that PBS puts out, please email them to the El Paso County Medical Society, and that email address is epmedsoc@aol.com. We can have them answered by one of our doctors, and we'll also address them on the next program that we have. This evening's program is underwritten by the El Paso Children's Hospital, and a big thank you to the El Paso County Medical Society for bringing this program to you. I'm Catherine Berg, and you're tuned into the El Paso Physician. Hello, thank you for joining us for Pediatric Neurosurgery and also Craniofacial Surgery. This evening's program, we've got two doctors that are with us today, and we're also having this program in memory of a certain doctor, Dr. David Jimenez, who was the medical director of Pediatric Neurosurgery at the El Paso Children's Hospital, and we're honoring him this evening. With us this evening, we have Dr. David Yates, who is the medical director of the Cleft Cranial and Facial Clinic at the El Paso Children's Hospital, and we have Dr. Zaid Makushi, who is a pediatric neurosurgeon of the El Paso Children's Hospital and also the vice chair of the Department of Neurosurgery. So we were joking, although none of this stuff is a joke. It's like, oh yeah, you're a neurosurgeon. What do you do? There's all kinds of stuff that you guys do. On that note, though, I would love to just kind of start with Dr. Yates. If you can explain to the audience, not jokingly, but you two have the same discipline, but very different disciplines at the same time. What do you focus on during your day?
So I focus on deformities that people are usually born with of the face and the cranium. Mm-hmm. So these include cleft lip and palate. They include ear deformities, eyelid deformities, nasal deformities, jaw deformities, the mandible or the maxilla. And then also where we have a lot of overlap is when it comes to the skull. So in skull cases, the craniofacial surgeon and the pediatric neurosurgeon work very closely together to really help deliver the best and highest level care for these patients.
And I think that all of y'all can see from your angle, but we have, I call it like playing marbles up here, but we have different models of different skulls, and these are real people. These are real children, the formations of the real skulls of real children, which is fascinating to me, as you were just pointing things out prior to the program of different sometimes vein issues that are involved, palates that don't quite close. I mean, this is going to be a great show, and I like this guy here in the helmet. He's going to be some fun too. And Dr. Makushi, so you are handpicked and recruited by Dr. Jimenez, and so nice to have you here.
Thank you.
And to cover what it is that you do all day, every day, and you're really kind of the person that's taking over a lot of what he was doing. How would you explain that to our audience?
He had recruited me to add to as well the neurosurgery program. One of the two things that were missing at the time was epilepsy surgery and spasticity, which are two big areas where we still had a lot of patients that had to leave town. And the closest centers are at least 5 to 6 hours away in order to get specialized treatment. So in his vision, which we're continuing to try and accomplish and build on, is to have all those specialty services for neurosurgery, and El Paso Children's is expanding with all the other specialties, so that patients, for example, that I still see time and time again, that are following up from 4 years ago traveling to Denver, Colorado, or out to Houston, because no one was here at the time to help them to get specialized treatment, trying to transition to say, no, we can take care of it here. Mm-hmm. You don't have to have that worry on a year-to-year basis of where are we going to get the money, where are we going to stay, because we need to see those specialists. So the hope is that we continue to build on what we have here with the specialties and grow on it, so that things like as far as brain tumors don't need to be flown out. Epilepsy surgeries, which are a multitude of different surgeries to help cure in some patients, or even at least decrease the burden of seizures that occur in children. Spasticity, where we have a large population of cerebral palsy, for example, and affects their day-to-day lives. So those are specialized treatments called rhizotomies, where we actually deal with some of the nerves that help them walk better and mobilize, getting around in school, and dealing with all types of brain and spine tumors, deformities.
Man, he doesn't stop.
There's quite a few.
I was going to say, so I like the idea too, when we're talking about not just brain, but we're talking about all the neurosciences and all the neurosurgeries. And I apologize, but I was just like going through this. It's like, man, that's a lot more than I have here. I'd like to also focus later on too, how the microsurgeries goes. When you're looking at nerves, they're so, to my eyes, microscopic. And when you're looking at microsurgeries, and we're going to talk about that too, because you're looking at face and nerves and the face and the tongue and the teeth and everything else. When is it that you talk about birth defects? So you almost have a pre-knowledge that something is going to be happening and stuff that you're going to be working on. Dr. Makushi, are some of the things that you're talking about, when does somebody know to go see a doctor because maybe there's something wrong and I don't know what it is? I mean, these are things that you can't really put your finger on immediately. How many of them start in childhood, et cetera? And maybe kind of take that tangent.
A large number, and it even starts as early as prematurity, where we have children that are born too early. And a lot of them have a high risk of developing intracranial bleeds inside the brain, and then developing problems with, we're normally producing fluid, but we can't reabsorb it. So as early as that, it can cause pressure inside the brain, and we're not even fully born yet.
Wow.
So those require treatment interventions sometimes to stabilize, to let the brain continue to grow, and occasionally will require interventions to help continue to drain the excess fluid so that children can develop as normally as possible. But then even throughout childhood, where things as far as even dimples on the back may be an indication that there's something going on deeper inside the spine. Problems with the head growing too fast, is there something going on that's affecting that fluid balance? So all these very early on in life, we'll see that might be serious neurosurgical conditions that we have to take care of.
So let me go back to a pregnant woman then. And being able to see sonograms, I don't know how many are done these days. I know with my first child, there was one, and that was it. And my second child had like 3 or 4. So developmentally, as a woman is pregnant, how can they see? How is the sonogram able to picture all of this?
And that's been one of the fields that have been expanding over the last decade or so. Ultrasounds for screening, for example, where something is caught, they're being now referred earlier on to specialists. One of the things, for example, are the myelomeningocele, which is a spinal defect in the back where it's open like a book and it's not closed to protect the nerves. Now, some of these, if caught early, can be treated while in utero. So the baby is still inside the belly, you close it up and repair, and they have a better outcome. Others are as far as counseling. You can't do anything early on, but at least preparing and having discussion with the mother and the father to say, as far as this is what it looks like is going on, getting more specialized imaging, such as MRI scans, which we can do, and getting a better picture of the head in order to have that discussion. Well, this is what we might expect immediately after delivery. These are the things that we're going to watch out for. Help deal with that anxiety and have a plan in place for them.
So is there ever a time when you do surgery on the mother, on the baby, when the mother is still pregnant with the baby?
Now, currently we don't have that here, but there are. So one of the big trials that had come out that showed that there was a major benefit to treating the open spinal cord defects in utero before they were even born has now continued on to different areas, and we're hoping to bring that here. We still need to build that program, but it makes a huge difference in the outcome, including as far as mobility, ability to walk. They're dependent on instrumentation to as far as shunt fluid from their brain. So the entire outcome seems to be much better when we can fix these things very early on.
That fascinates me. I saw some kind of a program or a segment on that, and not too long ago, maybe in the last year or two. And it was just fascinating that you can even do that. Dr. Yates, I know we were together, I don't know, several months ago, maybe not quite a year ago, and some of the things that you talked about. So again, mother's pregnant. You're able to see that some of these issues are going to be an issue once the baby's born. I don't know if sometimes you have to take the baby early or not in those cases. I'd love to maybe talk about a case study or two that you remember that really sticks out in your mind of these skulls that we have on the table, or one that's not here, but just one that really sticks out that kind of explains like some of the interesting things that you're able to do and fix.
Yeah, okay. I think there's a couple real quick that I can bring up. So prenatally, when people are seen for their ultrasounds, different things are able to be seen. And as Dr. Makushi was just saying, more and more. So one of the things that was recently referred was a skull like this. And so you can see the skull looks triangular, and this is called Trigonocephaly. But basically, even as early as on the ultrasound now, they're able to visualize whether or not these sutures of the skull, which you can see this one's open, this one's open, this one's open, but this one is fused. This allows the brain to grow normally. So when we see one of these prenatally, it enables the parents or the pregnant mother to be able to come to the office. And we sit down, we have a conversation, we show an entire PowerPoint talking about the importance of earlier intervention. We like to operate on these kids when they're 1 to 2 months old, if possible.
Oh, so it's not immediately.
No.
And talk about why. I remember you talking a little bit about this last time, but why not immediately? There's a good reason for that.
Yeah, babies, now there are some babies we have to operate on immediately. I'll talk about one of those in a minute, but like something like this, it sometimes helps for them to just be a little bit older, right? Because anesthesia in a very small child is already, a very high risk game. So if you can wait just a little while, it really provides a lot better safety profile. So we do like to wait on some of these. This is one where we didn't wait. And you can see this child is born with a very small jaw.
Oh my goodness. Right.
And the problem with a small jaw like this is that pushes the tongue back. And then the child comes out unable to effectively breathe.
Wow.
Yeah, choking on their tongue.
Yeah.
So in this situation, this child needed an operation, within the first week or two of life. And until then, we have to actually provide an airway for the child. But we'll come in and we'll cut the mandible and we put actually these distractors on. And you can grow bone in a child at a rate of 1 to 2 millimeters a day.
Okay, tell me how.
So,
is this something you're implanting in there? Okay.
So this is called a distraction, and we do it for the skull, we do it for the midface, but this device right here, you can see, is kind of the same thing. We cut the maxilla off, and then we put one plate here, literally a screwdriver basically attaches here. And this is something that the parents do and they basically just turn it every day. And I've had older patients say it feels like their braces are getting tightened. So it's not painful.
Right.
But it is incredible because this baby's jaw is probably only 15 to 20 millimeters. And we turn it a millimeter a day. In 20 days, the child's jaw has doubled in size. And now we actually just extubated one at El Paso Children's Hospital. They were not unable to breathe. They were unable to feed. And we do this surgery. We just move that every day. 7 days later, the tube comes out. They have no difficulty breathing. They're starting to feed well. And it's really a life-changing situation for these kids.
So explain to me a typically developing child with bones. Is this, because it as you're talking about it seems awfully fast. So when you're looking at the strength of the bones, is there a certain point where there's a pause to then, let the stretching stop for a little while, get a little stronger, or is that even necessary? Because I know babies are, Dr. Makushi's like, he's literally, if you could see them, he just says sitting back. So on that note, come on into the conversation.
This is a great, conversation for him to be on.
It's like, I know that growth tissue is super, super fast, especially when they're brand new, right? And then it slows down through life. But explain how that happens.
Even when it comes to the brain. So one of the things that we always talk about with neonates and even premature neonates is that the brain is growing expected about 1 centimeter of head size a week. And that's just telling you the rapid expansion of the brain tissue.
1 centimeter a week.
Which is a normal growth. So you're expecting in premature babies that they're trying to catch up because they're trying to get that normal growth. And then as they reach their full term, even though they're outside the womb, then it starts to slow down slightly, but it's still rapid. But it's very, very fast early on because we really are, as far as generating new tissue, because that's what the body's supposed to do, what it's telling it to do. And that's the amazing part that we try and take advantage of when we can, and also to prevent injury to growing tissue such as the brain.
And this is nothing that you're doing, aside from, don't get me wrong, this is something that the body is doing.
Using
that
the
baby's
own
body.
regenerative as far as ability.
That's amazing.
It's incredible. I mean, you can, you can literally take off the entire skull of a newborn and it'll grow back. But you make a hole the size of my thumb right here.
And you can't, nothing. And so when does this stop? So I know there's growth plates. I don't know when that works in the brain, et cetera, but technically, if I'm thinking about orthopedic shows that we've done, right? Growth plates kind of close up and finish like 16, 17, depending on the person. When you're looking at the skull, when does that stop? And I know it's a little bit different for everybody, but in general, what would that be? And I'm throwing it to whoever wants to answer it.
Go ahead.
Dr. Makushi, Dr. Yates, Dr. Makushi, Dr. Yates.
I'll leave it Dr. Yates' hand.
Okay, sounds good. So basically, babies, similar to their brains, the brain is what pushes the skull to grow.
Aha.
So the growth of the brain, if a baby's brain is not functional, the skull will not grow. And they end up with very small heads. However, if the brain is normal, it will try to grow and grow and grow. In the first few months of life, the skull circumference grows 2 centimeters, 2 centimeters a month. But it slows down significantly. And by 18 to 36 months of life, that entire 18 months, skull growth during that whole time is only 2 centimeters.
Okay.
So the skull is actually one of the first things to complete growth. And especially when you're looking at facial development. So the skull is pretty much completely grown by 5-6 years of age.
That's why they're so cute.
Yeah,
It's like
right.
got
They
these
have
big old
huge
honking heads on these little tiny bodies. It's like, oh, yeah.
And then the eyes and orbits finish around
Yeah.
age 8.
Okay.
And then the maxilla, the upper jaw around 12 to 15. And then the lower jaw, 18 to 20. So growth of the face grows like this.
Okay. So on your point too, because there's a slide that we're going to show, and specifically unicorneal synostosis.
Yeah.
And you were talking about we've got different images at 3 months, 6 months, 12 months, 24 months.
Yes.
So just visually, if you could talk through what that is.
Yeah.
You can see the point.
So unicoronal synostosis, this is one of the conditions that Dr. Makushi and I get to treat together. And basically, it's a fusion of this suture, which is called the coronal suture, okay? So there's a coronal suture on this side that's normal, and there's the sagittal suture and lambdoids. But what ends up happening is, since this is fused, the brain is unable to grow in this direction, and the skull is unable to grow in this direction.
I see, right.
So it causes actually a twisting of the skull base. It causes it's like this, but this is a metopic suture.
Okay.
This is a unicoronal. So the kid that you're looking at in the slide right now, we used the pioneering technique that Dr. David Jimenez invented 27 years ago and really radically changed the world and the way this surgery is approached around the world by his technique.
Amazing.
So we used that on the child that you're viewing right now, and you can see this child. And what I want you to notice is the eye is initially up. That's the first thing that comes down around 3 to 6 months. And then the nose straightens out, and then the jaw straightens out. And then the last thing is this forehead. And by 2 years of age, or 2 years post-op, that kid looks 100% normal. And that is one thing that is really unique to operating early on these kids and being able to do this minimally invasive technique, which literally just requires an incision this big right here. And as you were talking about, it's the body doing these things.
Right.
That's what I love about this technique. We're literally just recreating the suture that was supposed to be there. And then, as David Jimenez would always say, he's like, brain is king. And the brain just pushes that bone where it's supposed to be,
right?
And how it develops in all of us. So sometimes it's the simplest answers
exactly
that are the most elegant, and that's really true.
Oh, I like that wording. The simplest answers are the most elegant. I like that. Yeah. We were talking a little bit prior to the show. So this is happening in El Paso right now, UMC, thank goodness, at El Paso Children's. When I know that there are children that come to you from not only outside the United States, but in areas of the world too. And I'm thinking to myself, 3 months is nothing. 6 months is nothing. When someone is diagnosed or thinking somebody in El Paso can help you, how, I don't even know exactly what I'm asking, but how does that come about? Like, where do the parents know how to talk? How do they know who's in charge of putting this together, the navigation of it all? I'm throwing that out to either one of you as well.
And I can talk a
Dr.
little bit about as far as
Okay.
even just identifying these,
Yeah.
which are hard because some of them are subtle enough that it can take a while even for parents, which is normal because your kid's doing well.
Right.
But something may be a little bit off. And sometimes there can be a delay until even recognition by pediatricians, which is hard because, again, these are subtle things that we're trained to look for. But sometimes you'll see them and you're not sure. Is it simply a child that's been laying on the back for too long and it's just a positioning from gravity rather than a true early fusion of the suture? But that's also where it's important educating community and educating pediatricians, where if there is any doubt with these, we're more than happy to receive the referrals or even to look at whether pictures or images in order to give our expert opinion to say, no, this does look like something that would benefit them treated early, instead of having that delay and having a more extreme surgery, necessary and helpful, but still a more extreme surgery that could have been avoided.
Right.
And I will tell you, when it comes to the national side of things and the way patients find us, believe it or not, it's generally Facebook.
Yeah, really. Social
and-
media. That's
And it's not doctors. It's these like I had talked to 2 patients today who, one is from the West Coast, one is from the central United States. And they both were talking to other parents on Facebook who had received similar treatments and conditions as their child. These are rare, as Dr. Mikushi said. So, I mean, even though they're actually very common when it comes to facial deformities, it's 1 in every 2,000 births. However, still, if you think maybe a pediatrician has 5,000 patients in their whole practice, well, that might be only 2 patients.
exactly.
So parents actually, I'd say, identify this 50% of the time, probably more or less.
And, and with this day and age too, and you and I were talking about before the show, there was somebody who was coming to El Paso, wanted to look at your program, and they literally looked up the El Paso physician in neurology, and you said that they watched the show. So even in that note, for anybody who's watching, if you Google the specific words, like if you're looking at craniofacial surgery, neurological surgeries, that they would get to this. So I just think that that's such a beautiful way to sometimes you get a bunch of stuff that's not necessary to be out there. But Dr. Yates, I want to talk a little bit about when mainly you focus on birth defects and you fix them, but then there's also times when somebody's in a crucial car accident, or when there's, something, brain injuries now with football season happening, with, just in general damages that can happen to the skull and to the brain and issues there. Talk to us a little bit about some of those cases.
Yeah, so I really, for me, I really focus on the face and the skull. And then if there's a brain issue, Dr. Mikushi is quickly roped in. But, I think it's really an interesting thing that I've heard my neurosurgery colleagues say, but it's very true. The brain is the face is the airbag of the brain. Okay? So all of this, as sad as it is, and how beautiful we like to think of our faces, the great thing is all of this can collapse. As long as this is okay, we can fix this.
Yeah.
And we do. I mean, we just had a 17-hour surgery where we were reconstructing an entire face, and it was a motor vehicle crash. But we get horses that kick people in the face. I've had 2.5-year-olds, 2 of them actually, fall into dishwashers and they're implanted. So there are a lot of facial injuries that occur, burns, grease burns from bacon. And, so there is a lot of that. And I am really proud to say that El Paso Children's is part of, basically the level 1 trauma center that treats all of the patients with these conditions in about a 400-mile diameter. So it really is the place where people are flown. We have patients flown from Arizona. We have patients flown from, Central Texas, all over New Mexico. Yeah. And really, it's great to be kind of that beacon of hope and light where we can help these people.
Yeah. And Dr. Mikushi, when the airbag doesn't protect the brain, let's talk a little bit about that. Now that the airbag deployed, but somebody really has now a brain injury, and where and how do you come in and your team? And again, just Give us different examples. That's always what captivates people and helps explain.
And I think it can't even be emphasized enough, because it could be as simple as the concussions that happen just with football, soccer seasons coming into play, regardless of the motor vehicle accidents or ATVs. But the concussion education, which luckily has gotten better with coaches to recognize concussions and keep people out of play, but there's still a reasonable number of kids or parents that aren't aware, where they've had 1 concussion, 2 concussions. And if you have more than 1, there's a serious risk of having severe injury and, in rare circumstances, death from repetitive trauma to the head. So that is part of that education where you need to watch out for those, which we're trying to, again, increase that awareness to society. And we've developed those protocols and as far as instructions for patients when they see us, and we'll follow them for the complications of the concussion. Some of them can be chronic headaches where they can't concentrate at school and need some time off. Others are more severe, where you need an intense team, including as far as the intensive care unit, the neurosurgeon, sometimes the neurologist will be involved if there are seizures, the trauma team, where it's controlling the pressure inside the brain as the brain swells, in order to keep it as normal as possible so that that child survives and is able to get back into society.
And when that's the case, if the brain is swelling, do you at that point make a physical relief in the skull to then relieve that pressure?
And that's where we do have an escalation of tiers, going from medical treatment for less severe, where we can give medications similar to just giving salt into the body, where it shrinks the cells a little bit. Sometimes that's enough. Other where there's been a major bleed or a major trauma, for example, where there's multiple fractures or blood inside the brain, we'll have to make a large incision, sometimes remove the bone for a period of several weeks to several months in order for that pressure to come down, and at a later date, reconstruct that skull.
Wow, reconstruct the skull. And again, it's an age thing too. Like after a certain age, it's a lot more difficult because there's not a lot of growth at that point. Is that correct?
That is correct. And depending on the trauma, some bones can be as far as preserved to keep and actually use their own bone later. Some of them are so severely damaged that we actually have to use implants that are 3D designed in order to reestablish that contour for the head.
So when you do have a 3D implant that goes in there, would that be something that's flexible to grow with the brain? And maybe in my head I'm thinking pediatrics, but it's not necessarily the case.
And it depends on the age.
Okay.
And that's where we do have the benefit of younger kiddos where they can form bone around it, versus older where they've already reached their maximal growth and you can put that in, they should be just fine.
Okay. Okay, Dr. Yates, I want to talk about nerves. Let's talk about nerves, because they're itsy bitsy tiny itsy bitsy things that are so important, right? So when you are reconstructing facial issues, just all around, and it's something is very important as swallowing and breathing, is something as is non, like smiling, which is pretty important, but you know what I mean. But how do you deal with the nerves when you're reconstructing this face? You were just talking about the 17-hour surgery.
Yes.
How much of that is nerve portion?
Actually, interestingly, very little of it. And the thing about nerves is, usually when a face is crushed, it doesn't the soft tissue around the face, right, which is what the nerves are in. Generally. The airbag? Yeah, the airbag is pretty flexible. Okay. So only if you really have a laceration, like a bad knife cut through here, and you have to realize it also has to go in the direction opposite to the nerve. So the facial nerves go like this. So very elasticy. Yeah. So they kind of, But I mean, I'm thinking of a case Dr. Makushi and I did this morning. We were talking about the nerves, and we were reconstructing the front of a forehead on a child. And so in this case, it's if you are not careful with your dissection, and we were talking to the trainees about this, if you're not careful with your dissection, you can clip this nerve and the child can never move their eyebrow again. Right. So it's critical that we have all these kind of rules, surgical rules, things we don't violate. So when you do a certain type of surgery with a certain type of dissection, you always do it in a manner to protect the nerves. Right. Okay. Now, if you do end up cutting nerves, unfortunately, especially when it comes to facial nerves, they're so small that it is pretty much, if you're anterior to it at this line, you're not going to be able to put those nerves back together. And that's what I've read about. I've read that they're so crucial that you can't reconstruct a nerve, or you can't
take a nerve from one place, at least facially. And that's
Yeah.
kind of where I was going with on that.
Especially with the facial nerve. Now,
Yeah.
with our nerves that supply sensation, like to our
Right.
tongue or our teeth, we can reconstruct those nerves because they're a little bit bigger.
Okay.
Okay. But interestingly, when you reconstruct a nerve, you can even take a dead cadaver nerve. If you're missing a piece, and you can put it in there, and the nerve will grow
Regenerate?
through that dead cadaver nerve and reconnect.
Really?
But the problem with that is that, maybe you can feel your tongue, but you're not really going to taste again.
Okay.
Right,
But you're
so-
able to move it.
But you
Like your
can-
brain is
yeah.
able to talk to that nerve and still
Yes.
do the movements that
Yeah,
it needs.
at least you have something,
Okay.
right?
At least you have
So-
something. Right.
But nerves,
Yeah.
that is one of the problems with nerves, And
Yeah.
Dr. Makushi he works on the biggest nerve of all.
Right, he does, he does.
So he might be a great person to talk to about
Well, I want to talk about epilepsy for a bit.
Okay,
'Cause I
yeah.
know that that's a topic that you work a lot in, and I feel like all of us knew the kid in school that had epilepsy, and if
Yeah.
there was a seizure, get everything out of his way, make sure he's not going to swallow his tongue. But many of us only know that. Talk about your work in epilepsy, and I'm 56 years old. So from when I was 10, there's a girlfriend of mine who had epilepsy when we were in school, and I watched her have a seizure, and it scared me to death. And so maybe that's just the image I have in my mind. But I know that there's so many new things that have developed since that day, medications. Feel free to just go on that note.
No, and I think you're exactly right, is that our view of epilepsy is very centered on our own experience, or honestly what we see in the movies or the shows, unfortunately.
Good point. Yeah.
And that reflects even on the patients that have epilepsy, or the individuals, because they're afraid to engage in society sometimes if they have uncontrolled epilepsy. And they're sitting, they want to go out to parties, they don't do anything because they figure it might trigger a seizure. So it can change a lot in someone's lives and what they can do, including as far as driving, certain career choices, education, because you're on medications to keep the seizures under control, but then those medications can have side effects. So anywhere from a 1 in 5 to 1 in 7 can have as far as seizures that still happen despite the medications, even after multiple trials. And some of them, if not all of them, at least should deserve a chance to go through a full workup, because there are opportunities sometimes for cure, where we can identify a certain area of the brain that's causing the seizures and then resect that if we safely can.
So is the word cure new in this world, in the epileptic world?
It's improved. It used to
Okay.
be localized to as far as things like temporal lobe epilepsy when we're talking to adults, which is
Okay.
a specific area in the brain, and one of the more common things where it's localized enough that there was a big enough trial that showed, well, look, this is our outcome where we're reaching a cure, no more seizures, in up to 70% of patients, compared to medications, which was sitting down to as far as 25-30%. So that was a huge shift of saying surgery does play a major role in helping these people out. But then other advances that are not cures, like vagus nerve stimulators, but can decrease the burden of severity, of frequency, and of medications by about 50%. And that can make a huge difference for both the patient and the family.
So when you're talking about vagus, the vagus nerve is something that I feel like this year I've heard so much about, and I'm fascinated with it because it controls everything. Explain to the audience what the vagus nerve is. You brought it up, and in all the highways and byways that this nerve deals with.
So the vagus nerve, this is the most interesting part about it, is about 10% of the nerve tends to control movement structures, which is just causing something to do something.
Okay.
But as far as the feedback back to the brain, that's 90% of the fibers. And it connects to multiple different areas in the brain. So all of our other cranial nerves, or nerves inside the brain, stop somewhere around the clavicle. And then the vagus nerve supplies stuff as far as all the way from the head, the neck, and then down for the rest of the body, including as far as heart, gastric organs. So it goes from everywhere and comes back to multiple places in the brain. So it's so spread out, which is why it was such a good target to consider for things like vagus nerve stimulators, or because of those relays. One of the theories was it might interrupt a seizure, and that could improve over time. And it's one of the few things that we have that if you have a good response from it, you actually continue to get better responses as years go by, just because of that change in the brain, that plasticity. So it is an amazing thing, that vagus nerve, taking advantage of so many connections in different areas and making use of it by just stimulating it.
And how do you stimulate it?
So it's a little electrode that we wrap
It's like a
around
little
the nerve.
pacemaker-y type thing.
It is exactly like it, and we give them a magnet just like the patients with pacemakers, just in case. And it's similar just to a battery that's inserted along the chest. So it's a very similar thing, but it stimulates that nerve. And there's different frequencies to find the right one that will help control the seizures. Now, it does take a while to take effect, can take up to 3 to 6 months. But if we do see a response, the good thing about it, as I said, is that you continue to see improvement over time.
I'm going down the rabbit hole on this because it's very curious to me. So with the stimulator, is there external stimulation, or does the stimulator read what the nerve is doing, what it needs to do? Is that something that you're able to control from the outside? It's very sci-fi to me.
It's getting better and better. And some of them are things where even I had heard of at the beginning of my training that were coming out that I didn't believe were true, because it was, we can do that now, and that's just technology. So there is RNS, which is as far as a little battery that's inserted into the brain that, similar to a defibrillator, can be put into different areas and then uploaded into a laptop to read. It's almost like a continuous monitor of as far as the activity that's happening from that area. And you can see how many seizures happened, the characteristics of the seizures, and then program it in order to disrupt those seizures to stop them from happening. So we're coming a long way, and we still have longer ways to go in order to, and that's the idea, is that there are surgical options. It's not just medications for epilepsy. That is really taking off to help these patients, because medications have side effects. And going to 2, 3, 4 medications can be very, very difficult and detrimental for people. So it's important to know there are other options.
I love this. We're nowhere near to closing up, but I want to make sure, because there are so many different side things going on here. Dr. Yates, coming here tonight, we wanted to get several things across to the audience. Yes. And again, we have this beautiful, colorful table. And I would love to know the stories of each and every one of these beautiful brains that were in these. But what is it that we haven't talked yet about that you would really like to talk about this evening? And you're going to get the same question as well.
I think one thing I would like to talk about is the most common facial deformity of all.
Cleft.
Which is cleft.
Okay, yes, absolutely.
And, a cleft lip is 1 in every 700 live births.
That's a lot.
It's a lot. And that is actually even more intensified in Latino populations and also Native American populations, both of which we have in abundance here in El Paso. So it is something that really affects a lot of our families here, and it can be transmitted from one member of the family, down to the next generation. And then a lot of times it's not actually genetically linked. So, but it is one thing that I think many mothers also find on a prenatal ultrasound, and it can be devastating and scary. And so it is really a treat. I do think this has been a change in our city. A lot of these patients are getting referred before they even have the babies.
Nice.
Which allows us to plug them into our nationally.
So on a sonogram, you can see the severity of the deformation prior to? Okay.
It's one of the great things about the advances in sonograms.
Right.
I mean, we have these 4D sonograms now, and you can see the whole face. And so our maternal fetal medicine colleagues, our OB-GYN colleagues are sending these patients very early. And it allows us to, so there's nothing, I think, that could be worse than expecting your baby, and then all of a sudden your baby's born, and then you're like,
yeah.
And that should still be a wonderful, joyous moment, because cleft can be taken care of. I mean, these kids do great. I mean, I love the stories of our cleft kids. I had one who brought us, they were graduating from high school, and they brought us their national debate speech award.
Oh, and speaking.
Right? So that was a huge deal for this kid.
Right.
But these kids do great, and they have to overcome a little adversity through their life. And I think this makes them so much more beautiful, and they really are beautiful people, beautiful kids.
And describe the different severities. I mean, there are some that are minor and almost just cosmetic, but it's rarely just cosmetic because it goes into the palate. Yeah. But visually you see it from the lips. But if you can explain what is happening on the roof of the mouth and the palate of the mouth.
That's a great question. So a cleft lip in and of itself is actually one of the least common, okay? And that is really just where the lip is only affected. Usually it's truly a facial cleft, which involves not only the lip, it involves the nose, it involves the bone of the face. This is a cleft kid, actually. So the cleft went straight through the bone of his maxilla, okay? And so these kids, and then basically you look into their mouths, there's no palates, and you can see straight up, basically to the skull base.
So the palate that we all have, it was just missing?
It's missing.
It's just not there.
It's just not there.
Didn't form.
It did not form.
Okay.
And so you're looking up at the base of their skull.
Okay.
But you can see, I mean, when we drink water, we have a palate and we can close that off
Right.
and swallow. Well, these kids, they just have an opening into their nose. So, milk and food can just pour out of their nose. And then also similarly with speech. So if you think of it, when you blow a balloon, the back part of your palate is touching the back part of the anterior part of your spine, more or less.
Right.
And that's closing off your nose. So you can puff out your cheeks.
Sitting here, do it as we're sitting here.
You can puff out your cheeks. These kids can't puff out their cheeks. Because they can't create a pressure gradient. So they also can't say words that require that. Like pizza. The p sounds like
you need to have pressure.
It all comes out of their nose. So these are severe functional defects and issues that these children need to overcome. But the great thing is we have great surgeries that are not big surgeries that really can make a huge difference in these kids' lives.
That's amazing to me, truly. Dr. Makushi, there's a laundry list of things. I mean, I can actually show the audience, like, there are all these neurosurgical things, and literally I got to you guys and are like, oh, let's not focus on all of those. So instead, I'm going to, I'll just show this again. But let's focus on, I know epilepsy is a topic that you're super interested in, but cerebral palsy, there's a clinic that you all are looking at putting together or in the process of putting together, and just some things that you see that are up and coming at El Paso Children's.
So cerebral palsy is the most common motor dysfunction that can happen in children. So it's one of those things that everyone either knows someone, has someone that's been affected by cerebral palsy. And it's a wide spectrum. It's a big umbrella term where there's different severities, very severe where you're going to have to be transported in a wheelchair, to walking independently but requiring orthosis on your ankles, to needing reverse wheelchairs or crutches. Spasticity is one of the big parts where it's an increased tone in the movement of the hands or in the legs, and that happens in up to 80-90% of kids with cerebral palsy. And you can imagine a kid that's trying to play soccer, or as far as run around with the other kids, and then getting caught because that leg keeps tripping him, or even more severe where he's trying to catch up with the other kids and using the crutches. So one of the things that has taken off over the last 2 decades by being spread in more and more centers is the selective dorsal rhizotomy. So the rhizotomy is where the nerves, because every time you touch the leg or you move it, those sensory nerves don't have that information coming down from the brain because it's been injured to say, no, it's okay. Someone's just as far as you're touching your leg or you feel something. It bypasses, stimulates the area that says crunch down, and you get that increased tension. So selective dorsal rhizotomy, selective because we pick very abnormal nerves in the back and it's in the spine. And then rhizotomy is cutting those nerves. Not all of them because we want to keep sensation in the legs, but enough of them so that that tone is now very loose. And that makes a huge difference for kids.
So it's like ablation of certain nerves to help the other nerves.
You are exactly right. In fact, the older procedure used to be ablation of the spinal cord.
Oh my gosh,
that had a lot more consequences to it. Some kids had very good benefits in more severe cases, but in the minor cases, that benefit risk tend to seem to equal. So the selective dorsal rhizotomy has been spreading more and more because it's been taught more and more, although it's been available since the early 1920s. And that's really helped change things for these kiddos where now they can walk around with looser limbs and faster speeds, and it's made a huge difference in their lives.
So when you're looking at different kids that are already diagnosed, and obviously everyone's at a different stage, how is it that you find out which nerves to ablate? And again, when we're talking just the vagus nerve, it has like a billion different highways and byways. I don't know why I'm obsessed with nerves because they fascinate me, because there's just one little cut in a nerve and all of a sudden your smile's gone through the rest of your life or what have you. How is it that you find out which nerves are the ones you need to ablate? Do you do it while they're moving? Is it while the children are awake?
Almost similar to the nervous system being awake with the child being asleep. So it's a general anesthetic where they're put out, they're sleeping on their tummies. We take only one of the bones in the back where it's called the cauda equina, so the spinal cord ends, and then all those other nerves that go down to the leg that are just swimming in there are now exposed. And we take the back part of those nerves, those sensory nerves, and we actually stimulate them. So if you have one nerve that's supplying one area of the thigh, if you stimulate it, you should only get a response in the thigh. Now, if you're stimulating that nerve, you're getting the thigh, you're getting lower down to as far as the ankle, to the foot. You're not only getting the left side, you're getting the right side. This is a very abnormal nerve because it's spreading to places it shouldn't. So there's a scoring system for that, the more severe. So we aim to take 2/3 of those most severely affected by stimulating those nerves during surgery. Those are the ones that we cut because they're causing the most problems, and leave the more normal ones so that you still have sensation in your legs and you still get that benefit of a looser limb movement to help you move around.
So going through life now, and let's say we're doing this before the age of 10, 15 or so, maybe earlier than
You
that?
can continue to do it into adulthood.
You can?
Yeah.
Okay. And so now once you hit 20 and 30 years old, it just stays effects. I feel that nerves sometimes not regenerate, but they find different pathways to go do what they need to do. And so that's something that can be continuously ongoing.
It's one of those things where, from a functional perspective, there seems to be a plateau around the age of 5 and 6 for development. There's still an ongoing debate of whether it's better to do it early versus not. Definitely, if we catch it early, we'll operate around that age, ideally between 5 and 7 years old, and then early at 3 years old. But when it comes to those nerves, what we've learned over time is that if you cut closer to 30%, you do have a risk of the rest of the nerves becoming hyperactive and the spasticity coming back.
That makes sense.
So that's that threshold of at least 50 to 2/3
Gotcha.
to maintain that benefit. And there's studies going on 28 to 30 years follow-up in these patients that have maintained that loose tone in the legs.
Wow. You guys do a lot of cool stuff.
We do.
Dr. Yates, you had a great word, Makushi. Let's talk about following up. So and again, I'm just looking at some of the photographs that you've shown on some of these in past 24 months, and now you're looking at 4 years, and then 6 years, and then 10 years, and you're just beautifully talking about this young man, woman, not sure, who did debate. But in general, following up on severe cleft palate cases and or other severe cases that you've been involved with, how long is your follow-up? And then it's depending on each person, I get that. But how long does that follow-up stay with you? And I'd love some of the stories that you said last time. You've got kids that come back to you and sing your praises, it's like, hey doc, what's up? And you're looking at them like, what happened to you?
Yeah, there's one kid, I don't know if y'all can see him or not, but I included him because his skull is also right here.
he's the young man we talked about last time. Yes, I enjoy him.
Yeah, so he had, I don't know if we talked about, maybe we did. This guy had complete fusion of every suture. And he is, it's important to see these patients. And I think that's one thing that sets our program apart. Like we think that seeing our craniosynostosis patients yearly is important. Seeing our cleft lip and palate patients yearly is important because really it's the growth that determines whether or not you feel like the actual surgery you did all that long time ago was really as successful. And that's one thing that David Jimenez was incredible at. I'm still getting follow-ups from his patients 27 years later.
Oh, wow.
I just got a picture of another one. She's 23 years out. She just got married. Completely normal. She had this.
Wow.
100% normal development. This is sagittal suture synostosis. So you can see the skull is fused here, so the skull can't grow this way, and it only grows long. This kid too, who you might see, he had significant pressure on his brain, and the brain was actually, almost trying to like herniate out of the skull. And so when we took this bone flap off, you can see the imprint, and it should be on that slide, of the brain into there. This kid, he had 2 major cranial surgeries. I just saw him for his 6-year follow-up, and he said he wants to become a craniofacial surgeon.
I love that. That's what you're talking about. And how old is he? So 6-year follow-up. So is he 6, 7?
Yeah, so he's like 7 now, 7, 8.
Oh my gosh.
But really doing great. And I'll tell you, I think for anyone who goes into pediatrics, like seeing these kids grow and develop, is like the best part of our job.
Yeah.
And I love it when parents send us pictures from Christmas and Halloween or whatever it is. But also it's critical in keeping track of what you're doing, and are you helping these kids, or are there better ways you can help these kids? And so I think we have 2 nationally approved teams in town. One that is focused on cleft, one that is focused on craniofacial, which is out of El Paso Children's. And it's the only ACPA-approved craniofacial team within about 430 miles.
Oh, wow.
So it really is a unique thing. It really is a center of excellence, and it's great that we're able to do it.
I love that. And there's so many people that are coming here too. And it's, again, the biggest thing. We do not want people leaving our community to get treated. I want to cover quite quickly, because I know we did a program on it, but I found it fascinating too, brachial plexus. And maybe we can explain what that is to the audience. When I'll let you do it, since I just always think of my the inverted backpack, etc.
The brachial plexus, there's two major nerves that kind of come to supply the limbs, the hands and the legs, the brachial plexus and the lumbosacral plexus. Brachial plexus is just the big term that we use for the clinic, but we'll deal with any other peripheral nerves that are further out or involved lower down. The main thing about brachial plexus is that a lot of birth-related injuries. So pregnant women that have gestational diabetes, that may have children that are born with as far as larger size, bigger weight, can have fractures in the clavicle, have as far as difficult labors where the hand is pulled in one direction or the other, or the neck, and cause an injury to the nerves. Now, luckily in the majority of cases, they tend to recover, but in some they don't. So we follow them early because that's a big functional thing for the child, where a lot of them may become preferentially left-handed or right-handed because they just can't use the other arm. So it's catching them early to find out if they're not recovering in a timely fashion, is there a role for doing some type of nerve regeneration to try and improve their function to make use of that hand. And that's at least part of what we do at the Brachial Plexus Clinic for any birth-related injuries, but also any other nerve-related, whether tumors as well, whether traumas.
We haven't talked about tumors at all yet, really.
That is a long topic too.
You know what? Let's touch base on that, because that there's a lot of neurology stuff that happens there too. So tumors, and talk about areas and which type of cancers are most involved here.
So what I've seen is a variety of different cases, which has actually been rather impressive in El Paso. There's other centers that I've worked at that you tend to see some spectrum of it, but in El Paso, especially because of the catchment area, we'll get as far as more difficult cases, for example, that might be deemed inoperable because of the location, that are referred here that will take care of. A good example is the thalamus. The thalamus sits right in the middle of the brain and is as far as that highway controlling your awareness, because it connects everything from the top down to the bottom. And I had a patient that was referred to us that had a little tumor just sitting at the edge of the thalamus that had blocked off the fluid flow down to the rest of her brain. So she developed a swelling. Now, the treatment that she had was just placement of a shunt. That shunt caused problems, it overdrained, she came with the bleed. So what we did is we took out the bleed. We then took out the shunt by also taking out the tumor.
Taking out the bleed meaning drawing just...
We made a little hole in the skull, we evacuated that blood, and because she's so young, that brain just expanded.
Gotcha.
And because that shunt was causing problems and didn't need to be there, we actually went between the two hemispheres.
Okay.
We split a little opening in the highway between the brain and the corpus callosum, found that tumor, removed it, opening that pathway of fluid, and then removed the shunt from the patient. So they didn't need any instrumentation. She did just fine. I saw her now for her 6-month follow-up.
What?
Lovely, lovely girl. Yeah,
wow.
That we see on a yearly basis. Yeah.
Nice. Goodness gracious. Okay, we're running out of time, but I know there's something else you want to talk about. What is it?
You know, I think the only one big area is jaw deformities, because a lot of people have them.
Yeah.
So you see patients that like this.
And again, this is not cosmetic. This is eating.
No,
I mean, you don't have a good time eating, swallowing, etc. Yeah.
I had a 63-year-old in my office yesterday, and she's had this persistent jaw deformity her whole life, and she's like, I can't take it anymore. You know, she's got a lisp. It also causes breathing issues at night, so it exacerbates sleep apnea. She's had chewing issues. And so, you know, it's a really important functional thing that is not a long surgery. Takes 2 to 3 hours, and it can change their life forever. And that's very common. Those are people, that's everyone walking around. It can be a lot of different people.
So when you're looking at jaw surgery, especially this type of a jaw surgery where you're changing different things, good, there you go. Yeah. So do you make a model for every person that you're going to do a surgery for?
We don't.
Okay.
This one was a little bit more complex, and they needed these because of the cleft, the history of cleft. But basically, if you saw a jaw like this, We have different ways of cutting the jaw and preserving the nerves. You can see a nerve runs right through the jaw. So we actually cut the jaw lengthwise so that we miss that nerve, and then we can slide it.
Okay.
And you can slide it back or slide it forward. Similarly, we'll cut straight across the midface here and just pull this top part of the jaw forward. And then that not only expands their airway, but it also gives them a much more cosmetic smile. It also lets their teeth come together as they're chewing and lets them speak appropriately.
Do you ever have to rob Peter from Paul, whatever it is, as far as bones?
All the time.
Okay, I think
We're
we talked
always
about this
robbing
last
Peter.
time, right? We're always
Yeah.
robbing poor Peter.
Because, I mean,
yes,
you'll
you're
have
gonna need
people-
some buildup.
You'll have people whose jaws are out here.
Right. Yeah.
Well, I can't just, if I push that jaw back, they won't be able to breathe at all. So I gotta pull Paul out
Right.
and push Peter back a little bit.
Gotcha.
Right?
Right.
And
Exactly.
and then they have a nice balanced face and it works.
Right.
So yeah, you do.
So when you're looking at this, because I can imagine too, and I'm watching TV shows, right? You've got this 3D model on a computer screen, and you're trying to move things out. And I'm assuming that's how these are
Exactly.
3D printing out. How do it's almost like you're an artist sculpting.
Yes.
And is that what is your training when it comes to that?
Well, I think a lot of it is we pay attention to how the soft tissues drape over the face.
Okay.
How much tooth to lip show can you see? How does the nose and the labial angle meet? How should your nose look here or here?
Right.
What should the jawbones and the cheekbones look like as they come out through the soft tissue of the face? So those are cosmetically what we look at. And then, but also you're thinking functionally, because you have to get the bones in the right place, even if that may cause an abnormal look.
Right.
So I think an example of that would be sleep apnea. The sleep apnea patients, they come in, they're real retrusive. You have to bring them very far forward.
Right.
But then they don't need CPAP or any breathing aids at night.
Okay. Gosh, this has been such an incredibly interesting show. I mean, really, I can go on and on and on. Dr. Yates, thank you very much. Dr. Makushi, thank you. And again, this show is in memory of Dr. David Jimenez with El Paso Children's, who is the medical director of Pediatric Neurosurgery, and again, the inventor of all kinds of things that I think are going to be built upon for years and years to come. Again, if you want to watch the show back, you can do it several different ways. You can go to KCOS TV. Actually, now it's PBS El Paso. You can still do it through KCOS, but pbselpaso.org. You can also go to the El Paso County Medical Society site, and that's epcms.com. And you can always look us up on YouTube, which a lot of people have been doing. So just insert the word The El Paso Physician. If there's a certain topic you're interested in, write that in, and YouTube just magically shows all these things up. And if there's a question about the show, either this evening or shows that we've had in the past, feel free to email the El Paso County Medical Society. And that email address is epmedsoc@aol.com, and you can email your questions there, and we will address them here on your show. Thank you so much for watching. This is the El Paso Physician. I'm Catherine Berg. Good night.